Welcome to all my dears. Today we are going to discuss about the clinical examination of abdomen. As you know, inspection, palpation, percussion and auscultation plays great important role in the clinical examination of a patient. But at the same time, we have to complete some prerequisites for the same. It means that we have to explain and get consent from our patient for the physical examination, because if our patient is not aware about the physical examination, that may lead some unpleasant situations. So that we have to explain what we are going to do and what we are expecting from the examination and how can we use the findings etc. to our patient, and for the same you must get consent from your patient also. If you are going to do such physical examination, and if your patient is a female one and you are a male, or if the doctor is a female and the patient is a male one, in such situations there should be a hospital attendant or nurse should be there. Otherwise, in unfortunate situation, after doing such physical examination, there may be some allegation may rise against the doctor. So to protect our side, there should be a third person, preferably a hospital attendant or hospital nurse should be there. About the clinical examination room, as you know, as far as possible, natural lighting has to be used. If it is not possible, good light or an adequate light must be present in the physical examination room. Regarding the position of patient, especially in abdominal examination, supine position is preferred, and the head end should be supported with one pillow, or the head end should be raised near about 15 degree, and like that. To relax the abdominal muscle, you can use one pillow just beneath the knees also. Otherwise, if we ask our patient to flex his legs, the same may hamper the abdominal examination in some situations. So it is better to keep a pillow just beneath the knee joint. And regarding the position of doctor, the doctor should always be on right side or on the lateral side of the patient, or the position may be at leg end also. For the proper exposure, you have to undress from xiphisternum to symphysis pubis. As we mentioned in our earlier classes, the steps or sequence of physical examination as inspection, palpation, percussion and auscultation. But in abdominal clinical examination, unlike other physical examinations, auscultation is performed prior to percussion or palpation, as both of these could alter the regularity of bowels. So you should inspect, auscultate, percuss and then palpate the abdomen. Next, about the anatomical landmarks or segments of abdomen. As you know, for the proper understanding and proper explanation and to evaluate the diagnosis and differential diagnosis, we can classify the quadrant of abdomen either into 9 portions or into 4. So, as a routine one, we can split the abdomen into 9 portions by drawing 2 imaginary horizontal lines and 2 vertical lines. Here the upper horizontal lines joins from the lowest point of costal margins, say at the level of L3, and lower horizontal lines joins from the both sides of superior iliac crust. Regarding the 2 vertical lines, from right and left mid-clavicular point to mid-inguinal point of anterior superior iliac spine. By joining these two horizontal and two vertical lines, you can split or categorize the abdomen as 9 parts. Next, about the inspection of abdomen. Keep in mind, we cannot inspect or look over the abdomen from the top itself, so that you have to kneel to come at the level of abdomen. Then only you can appreciate the abdominal changes, not only from the side and from the leg end as well. During inspection of your case, the most important thing is to inspect regarding the shape of the abdomen, and what about the umbilicus, movement of abdomen, is there any dilated veins or visible pulsation, or whether there are any visible peristalsis, and what about the surface of the skin of abdomen, and what about the hernial sites. Next, about the shape of the abdomen. Normally you can see a flat or scaphoid abdomen or sunken abdomen. That means the level of the abdomen may be equal to the level of the chest of your patient, even though usually the abdomen may little bit sunken or scaphoid in shape as a boat-shaped abdomen. And at the same time, the sunken abdomen can also be seen in various conditions like severe emaciation or exhaustion, or in malignant conditions, etc. also leads to some sunken level of abdomen. At the same time, the abdomen may be distended or protruded out, and the distension or protrusion of the abdomen may be generalized or localized also. In generalized, distension may be due to obesity, flatulency, or the same may be due to feces, that means due to severe constipation, or the abdomen can be physiologically protuberant, especially in pregnancy, or in retention of urine, that is full urinary bladder. So fat, fluid, flatulency, feces, fetus, and full urinary bladder, that is 6F, can be considered as the mnemonics of generalized distension of abdomen. The localized abdominal distension may be due to some specific abdominal pathology like huge splenomegaly or very huge hepatomegaly, or any other abdominal mass or tumor may cause localized distension of abdomen. Next, regarding the umbilicus. As you know, normally the umbilicus is placed centrally, and on inspection usually it is inverted, and very slightly the same may be retracted also. But in pathological situation, the umbilicus may be everted or protruded out, especially in herniation of abdominal contents, as in case of umbilical hernia. Position of the umbilicus may be deviated due to localized swelling in abdomen. A transverse stretching of the abdomen can also be seen in distended abdomen. Next, regarding the movement of abdomen. Normally during inspiration and expiration, and specifically during inspiration, the abdomen moves forward or upwards, and the same may get backward during expiration. That means during the inspiration it moves forward, and during expiration it moves backwards. At the same time, in any form of abdominal pathology, say paralytic ileus, or in conditions like generalized peritonitis or localized peritonitis due to various abdominal pathology, the movement of the abdomen may be restricted as an adaptive mechanism of our body, and there may be very diminished or very minimal movement of the abdomen can also be seen, and it is known as a condition of silent abdomen. Next, regarding the possibility of any dilated veins over the abdominal region. Normally, there may be very small subcostal veins may be present, and at the same time, regarding the position of patient, to evaluate the possibility of dilated vein, ask your patient to stand up, and in standing position, you can inspect the veins, especially in patients with vena cava obstructions or due to any other pathology. As we mentioned earlier, normally small subcostal veins may be present, and it is usually a physiological one, not a pathological. At the same time, the tortuous veins can be seen if it is present mostly on the lateral aspect. So if your patient is having any tortuous vein over the lateral or the both side of your body, mostly it may be due to inferior vena cava obstruction. And if the same tortuous vein, if it is present over the or around the umbilicus, usually due to increased portal hypertension, or as in case of portal obstruction, if it is present, and that condition is known as caput medusae, and it is due to the opening of portosystemic shunt. Regarding the possibility of visible pulsation, normally those who are very thin or nervous subjects, epigastric pulsation may be seen, and the same may be very physiological one also. And if the epigastric pulsation is very expansional one, usually that may be due to aortic aneurysm. Regarding the possibility of or visible peristalsis, as you know, normally no visible peristalsis can be seen in a healthy one, even though our patient may having some problem. If there are any hypertrophic pyloric stenosis due to the mechanical obstruction, you can see epigastric pulsation, especially over the left hypochondrium, and the direction of peristalsis may be from left to right direction. Likewise, if there are any distal colonic obstruction, the peristaltic movement usually from right to left direction. So in pyloric obstruction, the peristalsis may be seen in left to right direction, and in distal colonic obstruction, the peristalsis may be in right to left direction. And at the same time, if there are any small intestinal obstruction, especially distal small intestinal obstruction, the peristalsis may be usually seen in pubic area or just below the umbilicus, and on inspection you can see a special pattern of peristalsis can be seen, and that is known as step ladder pattern of peristalsis in distal small intestinal obstruction. Next, regarding the surface of skin, on examination or on inspection, if your patient's abdominal skin is very smooth and shiny, that indicates that distended abdomen. So in distended abdomen, the skin may be very smooth and shiny. At the same time, on examination or on inspection, if the skin is wrinkled one, that means previously the patient may be very obese one, not due to the emaciation or due to the exhaustion, the skin is getting wrinkled one. And regarding the stretch marks, the stretch mark may be especially seen in obesity or suddenly developed ascites, and the same can be also due to in pregnancy. But in pregnancy, it is known as linea nigra. And some endocrinal disorders like Cushing syndrome, you can see the same striae or the stretching on examination. The stretching may be seems to be like that of pink or white in color. And regarding the scar marks, as you know, If there are any scar marks, usually that may be due to any injury or maybe a surgical origin. And on examination or on inspection, if the scar seems to be a very pink or red in color, usually the scar may be in a very recent or a very new one. And if it is very old one, usually the scar may be seems to be very white in color. So on examination, if your patient is having any stretch marks or scarring or any other color, you have to mention about the location, site, size, and whether it is healed or not, etc. has to be mentioned in your case taking performer. In some situation, your patient may having complaints with the bluish discoloration of abdomen, especially in and around the umbilicus or in the flanks, along with the severe persistent abdominal pain. It is usually due to acute pancreatitis, especially in hemorrhagic pancreatitis. If it is seen, as you know, it is known as the Cullen sign or Great Turner sign. So in acute hemorrhagic pancreatitis, due to extravasation of blood or due to hemodilution, you can see bluish discoloration. And if there are any enlarged vein, that may be due to emaciation, portal hypertension, or inferior vena cava obstruction. And the peristalsis is usually due to intestinal obstruction. And next, regarding the inspection of hernial sites. As you know, the possibility of herniation may be in, or that can be seen in epigastrium or in umbilical region or in inguinal region and in femoral one. To inspect the possibility of herniation, again you have to ask your patient to stand, and after standing give direction or instruct your patient simply to cough, and by a simple cough you can see if there are any expansion of the hernial sac. If so, that may indicate the possibility of herniation. So from simple inspection itself, regarding the shape, umbilicus, movement, possibility of the dilated veins or the visibility of pulsation or peristalsis, about the texture of the skin and the possibility of hernial sites, etc., that will give a great clue regarding the underlying pathology, and the same can be achieved by simple inspection. Thank you.